Looks like it's straight up 4 o'clock in the mountain time, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast, and it is Tuesday afternoon. Do you know what that means? I guess it must, because here you are. It's Fertility with Fink and Friends, and I'm Dr. Randy Fink, live via internet from Colorado Springs, where it is great to be with you, CNY Nation. Happy to see everybody here today. I see all my friends are joining, and oh gosh, the first one over here, Krishna and Ali, my dear friend Ali. Hello, my friend. Thanks for being here. And on the CNY side, it looks like Malik 3030. Glad to see you. You are number one. You guys are number one in my day. How about that? Over on the Facebook side, we've got Mayeli and Tiffany. Great to see everybody. How's your week been? It's Tuesday, which is always, I part of me would have said I'd rather do this on Thursday when, we're getting closer to the end of the week instead of the beginning of the week. But you know what? It's just you leave these things out in front of you, and the possibilities are endless for what may be happening during the week. Our thoughts certainly go out to our friends in Hawaii and our friends on the West Coast who are dealing with the flooding and the storms and not to mention the wildfires up in the Northwest. And gosh, these are challenging environmental times, aren't they? Well, so let's see. Haley on the Facebook side, good afternoon. Great week. Anxiously awaiting my full cryo report coming from the retrieval last week. So the cryo report happens when everything is done and over. So what happens actually with that is that, let's say that you have an egg retrieval. Egg retrieval happens. Eggs go to the lab. We have partner sperm. Sperm goes into each egg and fertilizes those eggs, and that creates your embryos. Those embryos will grow up to whatever point we will grow them up to, at which point they are frozen, and then you get a report in your portal that has the grading of the embryos. It has the pictures of the embryos. I like to say it's everything but the names. That's up to you. And it's a little disconcerting, I think, when people get their, they do their retrieval and then they don't hear, and they get the day afterwards, you get a phone call that tells you how many of the eggs fertilized, how many embryos we have, and we confirm the plan. But then after that, you don't hear anything else from our lab for a full week. And I know that that's disconcerting because you want to know what's going on with your embryos. But I always say, well, we'll babysit the family. You don't have to worry. We'll take care of everybody here for you. They don't want to pull the embryos out to mess with them. They don't want to have to pull them out of their growth medium and their little incubators because they want to not disturb them and let them grow. So it's once that process is over, when things are finally ultimately ready to be frozen, that's when you get your written report. So Haley, it's a coming, my friend. It's coming soon. Oh, we've got Kirsten, we've got Melissa and Susanna. Hi, Brandis. Our dear friend and nurse practitioner here from Colorado Springs has joined me, as well as my dear friend in Kentucky, Amber Vince. Thank you, Amber, for being here as always. So let's see what else is going on. This is Fink and Friends. I am Fink. You are Friends. Sometimes we'll have a special guest on here, but tonight you are my special guest. I want to share one thing that I found this week that I really thought was amazing. It has really nothing to do with fertility, but some to do with medicine. Something I really honestly can't recommend highly enough. There was a Netflix series that I started to watch last night. It's one of these limited series. There's 6 episodes of it, sort of like it was for the Dahmer series, which also was extremely good. Netflix is just doing some great production, but this is called Painkillers. And if you haven't seen it, oh my heavens, I can't recommend it highly enough. It has to do with the OxyContin days, Purdue Pharmaceuticals, the Sackler family, and the use of opiates. and how that crisis really kind of evolved in the United States, secondary to at least allegedly that pharmaceutical company. The production is amazing. The acting in it, it's done as a drama. It's based on a true story, but a lot of things are dramatized. Matthew Broderick is in it, who is wonderful. The performances are great, but the fact is that it's really based around a true story. And as I was talking with some of my colleagues today, I was there. I was prescribing medications during those times, and I had the same kind of drug reps coming to me saying the same things to sell that narcotic, that opiate product, which is, they call it like heroin in a pill. The same thing that they represent in this production, and it was so very real, and the way they marketed that drug. I mean, honestly, it's fascinating, and once you start to watch it, it catches you. It moves along quickly. It's so well performed and so well written, so well done that you won't want to turn it off. It's extremely entertaining, but also even more so because it's interesting. So there's Fink's plug for the week of what to watch on Netflix. So I hope that you'll get some enjoyment out of that as well. Let's see what we can do to get to some questions here. And folks talking, we've got our friends on my Instagram account over here, which is Randy Fink MD. Feel free always to instant message me if you would like. We've got the CNY Instagram side here. We've got LinkedIn and YouTube and Facebook right here in the middle. And just a top of the afternoon, good evening to everybody and welcome. Kirsten is telling me that our last transfer, they said, look at all those follicles. I usually have 0. Would they be available to ovulate on the next cycle since the FET failed? Okay, and that's in a transfer cycle. So what happens in a transfer cycle is that we are monitoring your it depends on, if we're doing a natural cycle, we're monitoring your own eggs, your own follicles in your ovaries, and we're watching them grow until we reach the point that one of them becomes what's known as the dominant follicle. And that little follicle, and that term, I remember in medical school before I really understood, that term always really confused me. Why do they call it a follicle? Because that means it's like a hair follicle. Is there hair in the ovaries? Do the ovaries have hair? Not generally. There are actually some types. So there's one particular type of cyst in the ovary that's called a dermoid. And a dermoid, if you look up pictures on the internet, you'll be like, ew, it's full of like fat, and it can have teeth, and it can have hair. But that's not generally the type of follicle that we're talking about in the ovary. So in a natural cycle, we're following that follicle, which is the egg house, and we're watching it grow until it's ready to be ovulated. So Kirsten, I think what you're saying is that you had a bunch of follicles, and they could see them doing their thing there. While those follicles in particular will probably not be available next month, what it speaks to is that you really got something good going on with your ovaries there. They're responding, they're awake, they're doing their thing. But sad to hear that the FET was not successful. And that's the other thing I want to mention. I think I said it last week. I hate to talk about how a cycle was a failure. And, we mentioned that a little bit. I know I did talk about it last week because we were talking about, what it feels like and how upsetting it is when things don't work out the way they're supposed to. And I really would emphasize as strongly as I can that it's not a failure. There is not a thing that we can do, even if it doesn't work out the way we want for it to. There's not a thing we can do where we're not learning something about you and about the way your body responds. So even if it's not successful, i.e., you ended up with a positive pregnancy test or later on down the line, a live birth, every cycle has its own type of success because we learn about your body, and we can take those lessons and apply them next time when maybe we can make a difference in the outcome. So please think about it that way. All right, let's see what else we got going on over here. Looks like, all kinds of friends on the CNY side. Hi, Alyssa. Hi, Nancy C. Let's see. Looks like Lena Villacorta. Hi, Dr. Fink. I know Dr. Fink. Oh, yeah, that's me. I was recommended to get a laparoscopy, hysteroscopy. So how soon can I start my next IVF cycle? So when you have a laparoscopy, we're basically under general anesthesia, placing a little camera through your belly button to take a look around on the inside to see what we can see. Most of the time, what we're looking for is endometriosis, because if we see endometriosis, we want to remove it. The endometriosis we can see, as they say, is the tip of the iceberg. So we want to take out what we can see, and sometimes we'd still treat with some medical therapy after that as well, depending on how much is there. Generally speaking, once you return to a normal cycle, so that is really with your next cycle, you could start IVF there. Same goes with a hysteroscopy. Both of these procedures are generally done in the first portion of the menstrual cycle. And why is that? It's what we call the follicular phase. Why do we do this during the follicular phase? Well, because then we know that you're not pregnant. That's a perfectly good reason, as if you need another reason. But if you're in the beginning of the cycle, you haven't ovulated, you haven't released the egg, and so we know that you couldn't have accidentally gotten pregnant, because we don't want to be giving you general anesthesia, or in the case of the hysteroscopy, we don't want to be placing something inside the uterine cavity when there's possibly a pregnancy there. If we did this, let's say day 17 or 18 or even day 20 of your cycle, there is a possibility that you could have ovulated, you could have conceived, and your pregnancy test would still be negative. So not a good idea, especially in someone who's trying to get pregnant. And the other issue is, as far as a hysteroscopy goes, what happens to your uterine lining as the cycle progresses, right? The lining gets thicker and thicker and thicker and thicker. So we don't want that lining to be so thick when it comes time to place a camera inside and look. But generally speaking, there, Lena, if we do these procedures in the first portion of your cycle, then you go on, have the rest of your menstrual cycle, your next period starts, you can start your IVF then. Now, sometimes we'll say, if we have to do something with a hysteroscopy, let's say we're removing a fibroid. Well, if we remove the fibroid, then potentially we're kind of cutting into the muscle from the inside, and that may take a little bit longer healing time. A polyp is a fleshy growth that's inside the uterine cavity that either sticks up like a tree trunk or hangs down like an icicle. And that we use a little instrument through the scope that's going through the cervix into the uterine cavity. And it acts kind of like a Pac-Man. It goes, and it actually does make that noise. If you want to hear it sometime, just let me know. I'll record it for you. And it removes the polyp, it removes that tissue. Generally speaking, when you have a period, the next time after that, polypectomy, which ectomize is to remove a polypectomy, then you can start your treatment then. Only thing that's different, sometimes if there's scar tissue inside the uterus that we are treating, or if we're treating a fibroid, it may take a little bit more time. And then that situation, you want to ask your surgeon. All right, what do we got here? Are there cases or pre-existing conditions where acupuncture, intralipid, etc., are recommended around transfer? Well, in fact, I always recommend acupuncture and intralipids around the time of transfer. So certainly here in Colorado, and I know in the Syracuse office, and I believe also in Albany. I don't know for sure about Buffalo. Acupuncture is offered at the time of transfer, both pre and post transfer acupuncture, and I feel pretty strongly that it's not an expensive thing to do, and it's something that may just make a difference. So by all means, I would say yes, you should do it. Intralipid is something that people often are confused about. The lipid therapy, also called Omegavin, is the one that we use now. What is that stuff, right? It looks like a milkshake. And so whenever I pass by the infusion room here, I see people getting their milkshakes through the IV. I'm like, you guys must be really hungry. Well, what it does is it's like an IV version of the keto diet. So it's just a very potent anti-inflammatory. It is particularly good. It's good for a lot of different things, but I will tell you it's particularly good for people who have an issue with natural killer cells. Now, what are natural killer cells? Well, it's a type of immune cell that everybody has in their bodies, but some people have a large amount of natural killer cells, or NK cells. And intralipid is a very good treatment for that. And you might say, well, I want to test my NK cells. You can test it. It's kind of an expensive test, but to be honest with you, the results from the test may not really correlate with the outcomes. And what I mean by that is that your NK cell activity may be higher than your NK cell count. So even though the count comes back normal, you still may have an NK cell problem. So that means that your own immune system is fighting against your pregnancy. And that's one of the things that the intralipid, again, is particularly good for. So strongly recommend it. Let's see. Kendra is telling me here, I learned yesterday that my FET was, well, you said failed, but I'm going to say unsuccessful. Gosh, Kendra, I am sorry to hear that. I had surgery earlier this year for severe endometriosis, and I have adenomyosis. Adenomyosis is the process where the glandular component of the uterus, which makes up that uterine lining, drops into the muscle of the uterus, and that's known as adenomyosis. And that's what Kendra has, along with endo. I did my 2 months of my Fembry, which is a medical treatment for both of those. Dr. Kiltz has said it's important that I get pregnant as soon as possible before scar tissue returns. Should I try a different protocol? I just did basic estrogen and progesterone, did an HCG wash, boosters, and lipids as well. So sounds like you did a medicated cycle there. And when you're on suppressive therapy, so you are on the Myfembree medication, we also can use Lupron and we can use Orilissa. So you are on Myfembree, Kendra, and when your hormones are suppressed and you're coming out of that suppressive therapy, I think it's generally best to either do a medicated cycle like you did, or to do a modified natural cycle, because your own hormones may not kick back in yet. You know, they may not work correctly, since a couple of months before, for that 60 days, we had the volume knob turned way down with the Myfembree. So I think you did the right thing there with the medicated cycle. I would next time go for a natural cycle if you have regular periods. Natural cycle, to me, is my preference. The medicated cycle has been around for 40 years. There's nothing wrong with it. Still, probably fully 85% of the frozen embryo transfer cycles in the United States are medicated cycles. But the natural cycle, which has taken on more significance in the last few years, may have a little higher pregnancy rate, may have a little lower miscarriage rate, and certainly has a lower risk of certain types of pregnancy complications that happen later on. So I would say, yes, a natural cycle may be a better choice for you moving forward. I would also there, Kendra, probably think about a PRP wash as well. So what happens is, we know that when we treat that condition medically, the endometriosis, the first month out of the treatment cycle with medication, you have a pretty substantially high chance of being able to get pregnant. So that's a good thing. But you retain that good juju, as it were, that good pregnancy juju, for about 6 months. So when Dr. Kiltz says he wants you to get pregnant as soon as possible, because eventually endometriosis starts to come back, eventually that inflammation kind of starts to return. But you do have a little window there where that medication is going to continue to help you. Natural cycle. is probably what I would think about there. Looks like Maeli is asking, what are your thoughts on using gonal and a trigger for an FET instead of Femara and a trigger? I ask because during my IUI cycles, my lining was thin with letrozole and the trigger, but with gonal and the trigger, it was trilaminar. Well, so it's a good question, but it basically what it means is that it becomes, when you use the injectable medications like Gonal-F or Follistim for things like an IUI or for things like an embryo transfer cycle, the most thing that it's doing is dramatically increasing your price because the medications are so expensive. I very, very rarely recommend gonadotropins like Gonal-F in an IUI cycle, because even in the best case scenario with an IUI, you may have, a 5 to a 9% probability of pregnancy, generally across the board. Whereas if you use that same medication, which is going to be the same price as you're paying for it in the IUI, and you do IVF, even though IVF is a little more expensive treatment, we can still offer you a, up to a 60% probability of pregnancy per embryo. So the odds are so much higher when you do IVF. I hate to see people spending that much money on something that gives you such a low pregnancy rate. You know what I mean? So that's one concern there. You definitely can, my friend, but I wonder if even doing a natural cycle for you may let that lining thicken up and be trilaminar. Some people just don't respond well to the synthetic medications, that you take these medications that we dump all kinds of estrogen onto your body to try to get that lining to thicken up. But what ends up happening is that the body says, I don't like that stuff. And maybe it doesn't get thick at all. So the first thing I think about when I see someone whose lining hasn't thickened, who purportedly has a normal inside of the uterus, I say, well, maybe next time we try natural, because it may be that your natural hormones work an awful lot better than the medicated ones. So, something to think about. Let's see, thoughts about best ways. This comes from Tamara. Best ways to prep the uterus before doing an FET from a donor egg. PRP a month before and intralipids. And which of the 3 PRPs? So I would do intrauterine PRP along with an HCG wash. Generally, I would like to recommend what we call our immune protocol level 3, which includes the intralipids. It includes some blood thinner, the Lovenox. It includes the low-dose naltrexone. It includes some Plaquenil or Prograf, which is an anti-rejection drug, as well as the antihistamine core and a baby aspirin and a prenatal. With a natural cycle, I always recommend that you do HCG boosters. The HCG boosters are processed in the body like progesterone, so it adds some progesterone to the whole program. In a medicated cycle, the HCG boosters really don't make too much of a difference, but in the natural cycle, definitely does. So that's kind of the way I would approach that. Let's see here. Oh, B. Cross is 24 weeks pregnant today. That makes me so happy. Love to hear that. We can't wait to see pictures of you and your baby. Please put us on the doggone Christmas card list, would you? Makes me happy. Fergie says, I'll see you on Thursday, and we are looking forward to that. And let's see what we got going on here. Melissa Maloney. Hello, Melissa. Did both an HCG and a PRP wash, and it was successful with her last transfer. Oh my gosh, look who I see has joined my Instagram, and that is none other than the Bama gal herself, which is my beautiful, sweet mother, who is sitting with my father, presumably, unless he's getting into some kind of trouble, and cavelling away in Mobile, Alabama. So thank you all for being with me today. Mwah! Okay, what else we got going on here? Emily Mortensen. Hey, Emily, I'll see you tomorrow morning. Oh, first retrieval. That's right. Your husband had his Tessie today, and the results were great. I'm glad to hear that. A tessie, in case you don't know, is a procedure where sperm are extracted from the testicle in the epididymis, so basically from the source. And we will often need to do a procedure such as that in the case of male factor. And male factor infertility can affect us probably about half the time. We talk an awful lot here, don't we, about women and their problem, because unfortunately, it's the females in our species who have to undergo all this treatment and all this work, when 50% of the time, it's us, it's the guy problem. And in fact, I've heard it said many times before, I have to get all the shots, I have to get the IV, I have to get the anesthesia and all the poking and prodding, and all you have to do is have an orgasm. So yeah, it's not a fair system, but thankfully women are the ones who maintain our pregnancies in this species, because trust me, if it were men, we would never be able to procreate. Men, we are babies. There is no question about it. JH and no, J Hand. JH and J Hand. Hi. Should you wait a full cycle after having COVID before starting stims? Does COVID affect egg quality? And I think the answer to that is probably yes. And my dear friend Brandis can attest to that. And she was, and this is, you'll see this on her Instagram where she's talked about it. She had COVID when she was preparing to do an egg retrieval for egg freezing, and when we looked at the number of follicles that were in the ovary in the beginning of that cycle, we knew kind of what her ovaries normally did. It had really cut down about half. And so we decided we're going to hold off here. And as that cycle progressed, we saw that it was a very different cycle than the way her cycles normally were. And when she ultimately proceeded with her egg freezing, I think at least 30 days after having COVID, the results were dramatically different. So I would say at least a month there, Jay Hand. And and look who is here with me as well on my Instagram side, and that is the man himself from Jamaica, the one and only Mr. Ian Deere. If any of you ever travel to Montego Bay, you let me know, and I will make sure that Ian's folks who are the masters of hospitality in Jamaica will take good care of you. So, Ian, thanks for being here. And hello, Brock and lovely wife. Which is better to create embryos, fresh or frozen sperm? And that really depends, Brock, because it honestly shouldn't make a big difference. The difference with fresh versus frozen sperm is that when you thaw a frozen specimen, so first of all, why would somebody need to use frozen sperm? Well, sometimes if partner can't be here at the time of IVF, we really need the sperm to be here at the time of fertilization. Otherwise, the eggs just have to be frozen, and then we have to thaw the eggs and then try to fertilize them. And embryos freeze better than eggs. So we always want to be able to make embryos when the eggs are retrieved. So if partner can't be here, sperm can be collected really any place and cryopreserved or frozen and shipped to us in our facility. When you thaw sperm, you may lose half of that sperm. If the sperm count is very, very low, then losing half that sperm might be a problem. If you have a normal sperm count, which may be 50 million sperm, if you lose half of it, you're down to 25 million. That functionally isn't really a difference in terms of a semen analysis, because how many sperm does it take to fertilize an egg? How many sperm does it take to fertilize an egg? One. So if there's 25 million, we're still probably going to be okay. If that sperm count was 50,000 or 100,000 to begin with, and we lose half of that, that's pretty significant in terms of the effect on sperm. But otherwise, thawing that sperm and its function, it should function really just the same, whether it's fresh or frozen. So there you go, Brock. This comes from Krishna. In my experience, Dr. Fink, that is me. What are the chances of mini IVF versus standard IVF working in a patient with suspected PCOS with an antral follicle count of 25 and a high AMH for age? All right, so let's talk about what those things mean. AMH, of course, is the antral, what's called the anti-Müllerian hormone, and that is a blood test we do that's considered a measure of ovarian reserve. When that AMH level is above about a 5, we know that the ovaries are going to respond like you have PCOS, or polycystic ovaries. Maybe not polycystic ovarian syndrome, but polycystic ovaries, which means they generally pay really good attention and you get a really robust response to the medication. So polycystic ovaries respond very well. The higher that AMH is, the more they are likely to respond. With an antral follicle count, so that's when we do an ultrasound in the beginning of the cycle, and we look to see how many of those little follicles are there in the ovaries. A follicle we don't use that so much as a marker kind of anymore, but what that tells me, a count of 25 is a lot, and that's kind of consistent with polycystic ovarian syndrome. So Krishna, what I think is going to happen is that you are going to have a very robust response. So how do we dose these medications? Because now you're asking about a mini dose. How do we dose medications in IVF anyway? Where do you come up with this? Is it kind of magic? Kind of. Well, it's a secret, and I wish I could tell you, but I can't. Dr. Kiltz will not approve, because if you realized how easy it was, then everybody would be doing it, and job security and all. We got to keep some secrets here. We generally dose the medications based upon age, because the way the ovaries will respond is generally based upon age. Secondarily, we think about that AMH, the anti-Müllerian hormone, which is going to tell us, are you going to be more likely to over-respond or perhaps even to under-respond to those medications? Well, in the case of your situation here, Krishna, I would say, I'm not sure how old you are, but if you were in your 30s, for instance, I would say the dose that I would use for you in that scenario is what I would give you if you were in your 20s, which is, in fact, the mini dose type of protocol. So how will you do with that? It's going to work probably very well. If we use an age-appropriate dose, which means a little bit higher a dose, odds are you're going to be hyper-stimulated, and that can make you, not feel well, and certainly can also get you sick. So there's my thoughts on that one, and wish you really the best of luck. And aloha to the only singing chef, which sounds super cool. We'd like to hear you sing. Let's see, this one looks like, I don't know how to pronounce the name, but Nivi Synthol, I think. Had my HCG 9 days post-transfer, it was 124, and then 12 days post-transfer, it was 333. Do I need to be worried that it's not doubling in 48 hours? Well, my friend, it's going up. So that's good news for starters there. If I were managing that, and my nurses in our clinic came to me with that, I would say, so far so good, you're headed in the right direction. 2/3 of normal pregnancies will double in 48 hours with that hormone level. So what would I do? I would check it again in 48 hours and see where it is. So even if it continued going up, but it wasn't doubling, what I would know is that, well, this is a highly desired pregnancy, so we're not going to do anything differently. We're not going to tell you, oh, well, it may not be going up, so you need to have a D&C because we have to end this pregnancy. The most important thing is that we want to know that you don't have an ectopic pregnancy or a tubal pregnancy. So, that's kind of the more important feature. By the time that HCG level reaches about 1,500, by the time the HCG level reaches 1,500, we should be able to do a vaginal ultrasound and see and confirm that the pregnancy is inside the uterus. So that's the point that we're looking for there, my friend, and my fingers are crossed for you. All right. Let's see what else we have here. Gracie Lou, does CNY Fertility have a religious affiliation? Caught part of a live stream from Dr. Kiltz and was surprised to hear some religious language. No religious affiliation, but Dr. Kiltz is a very spiritual person, and so I am fond of am fond of praying with people if they like. I will end my program by telling you God bless each of you, and often on my phone calls we'll say the same thing. So I think that we're all spiritual in nature. We all have different religious backgrounds, but I really see some miracles happening here. And to be honest with you, it's hard to imagine that, some of it certainly happens through science. But even when science says it shouldn't happen, sometimes it still happens. So I got to tell you, it's hard to believe that stuff is random. So I think that you'll find even those of us who are very grounded in science are still very spiritual in nature. And I think that's probably what you heard there, Gracie Lou. Let's see what we've got here on the Facebook side. Ariel, good afternoon. We did a modified natural last Wednesday, trigger shot 13 days ago, 2 faint positives yesterday, and today a digital positive and another positive on a line test that was much, much darker. That's getting darker, my friend. I think that means that things are going in the right direction. Wow, that is just awesome. Love to hear stories like that. So yes, the trigger shot is HCG oftentimes, or some relation to HCG. And so it may give you a positive pregnancy test, or sometimes if you're doing an HCG booster in a natural cycle. I always warn people the first pregnancy test that you do with if you're doing HCG boosters, it's going to be positive because we're giving you that pregnancy hormone in your body, which is going to do something. It's going to turn a pregnancy test positive. So you're going to need a second test in order to confirm whether you are pregnant or not. So make a plan for that. Know that that's normal. Know that that's a part of it. So there's no surprises and you don't have to feel anxious about it. That's just kind of what's expected. But if you're doing urine pregnancy tests and they keep getting darker and getting darker and getting darker, that's because there's more HCG in your body. And it's coming from someplace. Guess where it's coming from? It ain't coming from the trigger that you got 14 days ago, which should barely be left in your body anymore, if at all. Congratulations. Okay. Violet is asking, what would you recommend for someone that has done 9 transfers, 5 of which were unsuccessful? Well, so when I talk to people, which I do every day, about, what happens next after an unsuccessful transfer. The classic wisdom there, laparoscopy and hysteroscopy. What's that for? Well, the first thing is I want to know that uterine cavity is normal and it should be evaluated once a year. But a lot of people will slip through the cracks and they had a saline sonogram 2 years ago. Well, I want you to do it again. I would say, number one, we want to make sure that the uterine cavity is normal. With that, sometimes there are some things that we can check in the uterine lining. And I think that's worth knowing, that you don't have something that's called chronic endometritis, which is a chronic inflammation in the uterine lining. The laparoscopy part is, as we talked about a little earlier, because we're trying to make sure that you don't have endometriosis. There is a non-invasive test that we can do for endometriosis that I am a believer in. I like that test a lot. It's called Receptiva, and you can read about that online if you'd like, receptivadx.com. And I think it's worthy of kind of evaluating all those things. Do you have endometriosis? Is the lining of your uterus normal? Are you taking the right supplements? And what's happening with the hormone levels? And really, most importantly, what kind of embryos do you have? Because the most common reason that an embryo transfer is unsuccessful is, of course, because of the embryo. So there's my thoughts there, Violet. That certainly sounds like it's worth a consult to know that things are all normal. Facing Destiny. Hello, good afternoon. Do I recommend a fresh DE? I think that, does that mean donor embryo or FET with DE? I think you're asking about what happens with a donor egg. So when you decide to purchase a group of donor eggs, what happens? You get to select your donor, and then you can, based on a wide variety of different criteria, and then you will determine whether it is a fresh donor cycle or whether it is a frozen donor egg. So as you can imagine, there are quite literally, I think, tens of thousands of frozen donor eggs hanging out, in storage, waiting for someone who wants them or needs them. As I alluded before, embryos freeze better than eggs do. So an egg is just a single cell little item there, and the success on a thaw of eggs is generally said to be about 85%. Now, from an embryo standpoint, success on an embryo thaw is about 97%. So we'd always rather fertilize an egg and make an embryo. But let's say that you're purchasing a donor egg, fresh versus frozen. Well, so there's always a little bit longer of a wait for the fresh cycle, because generally there's a wait list, but B, there is, that is an individual who is going through her cycle, being stimulated and going to have, an egg retrieval at one of our locations. So there's always a little bit of a delay on that for those reasons with a fresh cycle. But if you're purchasing, let's say, 8 eggs from a donor, you are going to get 8 eggs from a fresh cycle. Now, they may not all fertilize, they may not all grow, but if you're purchasing 8, you're going to get 8. Whereas if you are purchasing frozen eggs and you purchase 8 frozen eggs, they have to thaw those eggs, and you may lose 1 or 2 of them, and you may only end up with 6 or 7 because they did not survive the thaw. So that's really kind of the difference with with a fresh versus frozen donor cycle. But in reality, once they have been fertilized, whether they came from a fresh or a frozen cycle shouldn't matter. All right, hopefully that's helpful there. Andrea is here with us this evening. By the way, it's getting close to be about 1/4 till top of the hour, so we'll be here about another 15 minutes or so, trying to get all your questions in live from Colorado Springs. I'm Dr. Randy Fink, and I am Fink, your friends. And what do we have here? Just like every Tuesday night, I am doing an IVF. I have 5 follicles, sizes 17 and 18. My doctor recommended to use Cetrotide 10 p.m. today, the day before my egg retrieval tomorrow at 11. Do we give Cetrotide the day before a retrieval? In some cases, yes, and in some cases, no. There is no harm to doing it. I suspect what may be happening there, Andrea, is that it may be that when they look, one of the hormone levels we look at is your LH. Excuse me, the LH is the luteinizing hormone, and what's the significance of luteinizing hormone? The LH surges, it goes up, and that surge of LH is what makes you ovulate. So if your LH is starting to surge, the doc may have said, hey, let's give you some more Cetrotide just to make sure that you don't break through. That's my guess at kind of what's happening there. And I got another note here, going to be meeting me in November. And It looks like the name is Assholy 88. I like the name. That's good. Hi to everybody on the CNY side. Sure is nice to see you guys. And then on mine over here, let's see what else we have. Kirsten tells me she's going to be doing ovarian PRP, an HCG and a PRP wash before transfer. Does it offer similar therapeutic benefits as doing an HSG in natural pregnancies? No. So when you do an HSG, so everybody hates the HSG, right? It is one of my least favorite things to have to do to people, the HSG, the dye test, the hysterosalpingogram, because it's crampy. It doesn't feel good. It's not something it's not the joy of people's lives to get it done. But there is some therapeutic benefit from doing it, right? It seems to clear out the fallopian tubes. It clears out some of the debris that may be, some of the cellular debris that might just be in the fallopian tubes. And so folks doing an HSG have an increased probability of pregnancy in the month or two after doing that test. So there's a therapeutic benefit. The uterine washes with HCG and PRP are designed to treat the lining of the uterus and to turn the volume knob up on some of the proteins and things that are associated with uterine receptivity, with the baby blanket that's going to be receiving that embryo. So a little different function there, but that's a really good question, Kirsten. Thank you for that. Let's see here. Hi, Andre. I'll see you in September. Very exciting. Deanna says, need to avoid LAP. Will 2 months of Lupron depot help before an FET? The answer is yes, absolutely. So in the face of endometriosis, we can treat generally with one of three things: Lupron, which is the oldest medicine. We've been using that for, probably 30 or more years. The problem with Lupron, and when they say Lupron depot, what that means is that it's a long-acting type of Lupron. So there is a small dose Lupron that can be used daily. Why you want to give yourself a shot every day? I don't know. There is a longer-acting Lupron that lasts for a month. And then there is an even longer acting Lupron that lasts for 3 months. Lupron, as I said, is the oldest. It's certainly the most proven, but it also is like a sledgehammer. It shuts off all of your hormones. It puts you into a temporary menopause. And as such, it has the highest side effect profile. Now, sometimes it's the best thing to do, and sometimes that's the one insurance will cover. So that's the one that we'll use. There are two other medications now that we can use for endometriosis: Orilissa, which can be taken once or twice a day, depending on the dosage, and another one called Myfembry. And Myfembry, I think, is probably has the lowest of the side effect profiles. It gives a little hormone. It's very specific to what it's shutting down inside, and gives a little hormone back to kind of minimize some of the side effects. So yes, Lupron will absolutely do the job, and that is will take results of an embryo transfer from less than 10% to greater than 60% in the face of endometriosis. So yes, indeed. Actually, going back to the question here, Brandis just answered me. I was thinking, we were talking about the effect of COVID on egg quality, and she said she waited 2 to 3 cycles, and I've just forgotten about the timing of that. Certainly, at least 1 cycle, 2 to 3 is what we did, and with Brandis, and we really there was a very notable difference, and I hope you're still there, that you could hear my corrected response. Oh, look, Jay Hand said yes. Thank you, Brandis. That's what I was thinking. Okay, good. I feel complete now. Let's see. My first FET failed, but my protocol has not changed. Was something supposed to be checked or changed? I'm trying again right away on cycle day 7. A nice, good PGT tested embryo, HCG wash and milkshake. So, here's the thing. I do get this question a lot when people say, oh, well, I did an embryo transfer and it didn't work. So we obviously we have to change something, don't we? The answer is no, not necessarily. There is cake and there's ice cream. Um, Cake and ice cream, that's a birthday. There's cake and there's icing on the cake. All right. The cake part to the embryo transfer cycle is the estrogen and the progesterone. So whether that comes from a medicated cycle or whether that it comes from a natural cycle. In a natural cycle, you're making your own estrogen and progesterone. We give you a little bit more. In the medicated cycle, we're giving you all the estrogen and the progesterone. The cake is the cake. There are not a lot of variations on what type of cake you get. You can either get a natural cake or a medicated cake. That's the story. So there's nothing really to change with that. The icing portion of the cake is the immune stuff that we do with it. It's that low-dose naltrexone, it's the Prograf, it's the Lovenox, it's the those things that are part of the intralipid, the milkshake. Those are the icing. Can you eat cake without icing? Of course you can, but does it taste as good? I don't think so. I happen to like the icing. Sorry, sort of lose you there. I like the icing. So when we can change the immune protocol, but really the only part to change from an embryo transfer cycle is what type of cake are you getting? Is it a natural cake or is it a medicated cake? And that's kind of what you got to know. Again, most of the time when something doesn't work, it's usually more of an embryo factor than it is anything about the cake or the icing. We put that icing on, the immune stuff, because, and every practice doesn't do it. We do it because it's going to help some segment of the population that we may not know who that segment of the population is. And if we don't know, it's not going to harm anybody. So we're going to sort of treat everybody with most of it in hopes that it's going to get on to those people who it's ultimately going to help. And that's the purpose of the icing or the immune protocol. So no, nothing by necessity needed to change there. This comes from Waimani, if I'm saying it right, or Imani. And that's why, even with a euploid, a tested embryo, there's a 60% chance, 60% probability that you get pregnant with that. It's not 100%, which means there's a 40% chance that it doesn't work. But, so there's always some embryo factor, even in a highly graded, tested, normal embryo. Know what I mean? Let's see what we got here. Monkey Mo, I like that name. Monkey Mo 86. Got all kinds of good names over here. Hello to Lindsay McIntosh and Melissa. Barbara in Miami has joined me. Thanks for being here, my dear friend Barbara, the most wonderful medical assistant there is at the Miami Center of Excellence. By the way, if you are in South Florida, the Miami Center of Excellence is a wonderful place for gynecologic care or to monitor your pregnancy treatments. Growing Primal says we got 6 healthy frozen embryos and FET won't be until November. What can I do to prepare my body? Well, Miss Primal, what can you do? Live healthy. Keto is the diet we recommend. What is it about keto? Well, I'm not Dr. Kiltz, and Dr. Kiltz can talk to you ad nauseum about keto and carnivore. Keto is high fat, moderate protein, and low carb. What's the most important feature there, in my opinion? Low carb. And whether you believe in keto or not, whether you believe in carnivore, whether you think it's Mediterranean diet or whether you think it's, whatever your belief system is, what they all have in common is low carb. Carbs are pro-inflammatory. I happen to think that keto is anti-inflammatory, but carbs are definitely pro-inflammatory. So anything you can do with fewer carbs is ultimately going to help you. All right. So that's that. What else? There are some supplements that you should be on. The supplements that go along with an embryo transfer cycle are, one, a prenatal. Everybody should be on a prenatal, really. I mean, Really. If you saw my Instagram post from I think it was last week where I said the three most important supplements for fertility. Number one is a prenatal. And I said, duh. If you don't know you should be taking a prenatal, you probably shouldn't be here. So take your doggone prenatal, would you? By the way, just as we're talking about prenatal, there is a wonderful prenatal that's on the Molecular Fertility website. And so I encourage it. If you're taking a prenatal from Walgreens, I think that's okay too. There's not a huge amount of magic that goes into a prenatal. Some of them have a stool softener. Some of them have a little more iron. Some of them have are coated, and some of them have a little more B6 for nausea. So you may tolerate. Some of them have this and that. So you may tolerate one a little differently from the other, but that's my 2 cents worth on a prenatal. That's number one. Fish oil is another good thing to take, the omega-3. CNY or Molecular Fertility does have a really wonderful fish oil as well. Number three, vitamin D. You should be on 5,000 units of vitamin D a day. If you're on 1,000 units of vitamin D, you are not on enough vitamin D. And you say, well, I go out in the sunshine. Well, remember, I came to Colorado here from Miami as a gynecologist in Miami. I had a lot of patients who were lifeguards, for instance, on Miami Beach. They were out in the sun all day long, and they were still vitamin D deficient. We have an epidemic of vitamin D deficiency. Get on vitamin D, even if it's in your prenatal. You should get 5,000 units of vitamin D a day. L-arginine is another thing that you should be on, as well as some vitamin E. So vitamin E, vitamin D, L-arginine, fish oil, and a prenatal. And that's a pretty good thing to do there, Senorita Primal. And I hope that come November, you are going to be very lucky. Let's see, is it possible to have, this comes from Just Valerie, possible to have a positive outcome with a 11-day post-transfer low positive? The answer is yes, absolutely. So if you do if you've done a blastocyst, a day 5 embryo, then we are going to be testing your beta right around now. And a low positive is fine because it may have hung around a little bit before it ultimately implanted. So positive is positive, and we should always be happy about that. Just Valerie. Fingers crossed, my friend. We got 3 more minutes here. Let me see what I can get in. Liz on Facebook says, is my video cutting out? I didn't realize video was cutting out. This video will be on both the CNY Instagram as well as my Instagram, which is Randy Fink MD. I believe it also stays on the CNY website as well. So you should be able to review it back. I'm sorry if my video was cutting out there, running into some technical difficulties. Let's see. This comes from Giura, who says, I had IVF before, and my doctor in Europe, in Cyprus, said that it is not possible to do a vaginal ultrasound after transfer. I was 51 at the time. In my own country, in Hungary, only vaginal ultrasound is used to determine pregnancy. I miscarried with twins 2 hours after the vaginal ultrasound. I'm worried now after my 6th transfer that it will happen in Syracuse next Monday, that the same thing will happen again. Well, so to say that you can't do a vaginal ultrasound, there's a portion of the vaginal ultrasound that we generally don't recommend early in the pregnancy, and that's what's using what's called the Doppler, which sends sound waves to be able to hear and measure the heartbeat. So at 6 weeks, I don't like to use that feature and measure the heartbeat. By 7 to 8 weeks, I think it's okay. We typically do that because we can measure that number, but there is nothing about a vaginal ultrasound that will cause a miscarriage. And to say that you can't do a vaginal ultrasound after transfer, well, you're not actually going to see the pregnancy in the uterus until between 5.5 to 6 weeks, and you may not see a heartbeat until even a little bit after that, but typically always going to be a vaginal ultrasound there. Well, let's see, folks. Looks like bits of lovely. Do you recommend berberine for PCOS? Already taking an inositol pre-IVF. Yes, berberine is a great supplement if your stomach can tolerate it for PCOS and controlling blood sugar and insulin resistance. Very good stuff. Looks like we are going to be out of time here, my friends, for another Tuesday. So I'm going to say from Colorado Springs, as always, it is such a pleasure and an honor to be here with you. Your positivity, your energy, all the good thoughts that we can share together and that you give amongst each other really, truly is a blessing, not only for me, but for everybody who's involved here. Infertility is not your book. It is not the title of your novel. It is only one chapter, and we are here to rewrite that chapter. Until next time, God bless you all. Thanks so much for being here. I'll see you next Tuesday. Good night.